On the Scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block at ACC 2015 in San Diego, and I'm here for On the Scene. With me is Mark Sabatine from the Brigham and Women's in Boston, my old competitor when I was at the MGH. Mark, as you know, has been talking about PCSK9 inhibition. So Mark, let's talk a little bit about it. People are bored to death now at this point, 2 days later, just hearing about the data. The data show PCSK9 is a dynamite way to lower LDL and actually decrease bad outcomes. So having said that, let's sort of go on and have a better conversation about what happens next. Do we need a bigger trial? Do we now wait for the FDA? Do you think that this is going to be just the next blockbuster drug that's going to be around?
Yeah, no, thanks for having me, Peter. I think we should have the large outcomes trials. We're doing one. Fourier is a 27,500 patient dedicated cardiovascular outcomes trial. That being said, the data are really very encouraging. And I think when the FDA reviews the package of information, the LDL lowering is powerful, there are genetic data showing that patients with loss of function variants do well. This is one other piece of the puzzle that's very encouraging for this class.
Okay, so when will those larger trials be done?
We don't expect the results of those until probably about 2017.
Okay, but FDA probably will see this drug for review before then, don't you think?
No, this summer they will. And so there'll be a gap between when the FDA reviews it and potential approval and the outcomes data, the big outcomes trials data about 2 years later.
Okay, so assumption the FDA will approve this drug in the end of summer. Who's going to be the best patient? If you were taking care of patients were in trouble, who would you choose for this new drug?
Yeah, it's a great question. I think there are three logical populations. The first would be patients who, despite being on a statin, we haven't controlled their LDL cholesterol to the target that we want. I think we can both remember the good old days when we had LDL targets. I think with the Improve It trial, it suggests that for some high-risk patients, ACS patients, even a target of 70 may be too high, that 55 may be better, and we'll need drugs to be able to get patients down to that level. The second group will be patients with familial hypercholesterolemia. Affects 1 in 200 to 1 in 500 Americans. Lifelong high LDL cholesterol. We can't get the levels down to low enough with statins, and they need additional agents. And then the group of patients who are statin intolerant, who despite best efforts can't be on a statin, and we need to find some good drug for them to get their LDL down.
Those are three major classes that, in fact, we bump into a fair amount of time when we're taking care of patients. So let me ask one last question, and that has to do with combination therapy, because the PCSK9 inhibition business has not been shown to be anti-inflammatory or whatever other magic that the statins can do, right? So is this something that's in addition to, or is this something that's in place of? Now, this takes away statin intolerant patients, of course.
Yeah, no, I think other than statin intolerant patients, it would be in addition to. Statins are very effective. By and large, they're very safe. In general, they're well tolerated, and they're generic now. So I would view statins as the foundation. This would be additional therapy on top.
Okay, so to quickly review for all those guys in the trenches out there, it's going to be probably the end of the summer before the FDA says yes to this drug, but once there, it looks like it probably will take off in a major way. And in addition to statins, may be exactly what we need to take care of difficult patients. Thanks, Mark.
Thanks.